Okay, I think we can launch. This is Christine Toriason speaking. I'm at FHI 360 in North Carolina in the United States, and welcome today to our monthly Global PrEP Learning Network. I don't know if I've mentioned this before, but this learning network used to be supported by the Options Consortium, and that project closed, so it's now being supported by the Choice Project, which is a collaboration between the EPIC and RISE programs, which provide technical assistance and service delivery around HIV prevention, care, and treatment in many countries around the world. We're very excited having you here today to talk about expanding access to PrEP through community-based delivery. And I think many of us have been, on the one hand, struggling with the challenges that COVID-19 have presented in terms of all of our service delivery, and particularly for PrEP, but also recognizing that an opportunity has arisen for us to think of new and innovative ways to move PrEP out of the facilities and into the community. Next slide, please. And so today we have two exciting presentations to share with you. One is from Eswatini, talking about the PrEP community service delivery program run by the Luke Commission. And the other is from Hiv Pharmacy, which talks about their last mile dispensing and distribution solutions. They are based in South Africa, but work in many countries in the region. Next slide, please. So I'd like to introduce our speakers for today. From the Luke Commission, we have Tiffany Riggleman, and she serves on their executive leadership team and as a technical director. And together with the local team, she works to build robust systems, responsive strategies, and detailed trainings to empower compassionate efforts toward epidemic control. I'd also like to welcome Fonnie Hendricks from Hiv Pharmacy, which is a subsidiary of Right to Care. He is the managing director of Hiv Pharmacy, and his focus is on strategic collaboration with key stakeholders to pioneer, customize, and develop technology that enhance efficiencies and healthcare outcomes in the last mile of dispensing, distribution, and collection of medicine. So we're going to have each of these speakers present, and then we will have a time for discussion as well. Next slide, please. For those who are still joining and might not have heard me earlier, we unfortunately do not have the opportunity to have the participants speak on a webinar. Everyone is muted, but we do welcome an active participation in the chat. We would love to have you ask questions, but also share your comments or experiences or reflections on how we can expand community-based delivery of PrEP. There is a chat function you will see in the lower right-hand corner. So if you're on Zoom, first you need to click the chat button on your bottom bar, and then that opens up a chat screen. You'll notice that if you look at the arrow next to the to line, you can select different people to send the chat to, and our request is that you select to all panelists and attendees. That way everyone can see the conversation. If you select just all panelists, then it just comes to me and the speakers and a few of other colleagues from the organizations presenting who are here to help answer questions. So please select all panelists and attendees. Next slide, please. Okay, so I think we are ready to launch. I will pass this over to Tiffany Riggleman to talk to us about their experience in Eswatini.
Hello, everyone. It's good to be with you today and just get the opportunity to talk to you about PrEP in the communities and how we've been able to have success in both PrEP initiations and ART refills at community level. Next slide, please. So the Luke Commission has been founded on the tenets of compassionate and comprehensive healthcare service delivery, seeking to reach underserved populations. And initially that was mostly rural populations, but in recent years, we've also expanded into urban populations as well. because even people in urban populations are underutilizing healthcare services, we found. We try to have a patient-centered approach that asks what do the clients need and how can we make the services convenient and accessible to them. And keeping that approach has helped us to innovate solutions that help us keep the client as the main focus. And then also with a lot of community work comes strong logistics needs with fleet and supply chain, coordination with outreach coordinators working in our hub office, and strong electronic platforms that allow for efficiencies. Next slide, please. This is just a little diagram of how we operate. We have a facility that's based in the middle of the country that operates 24/7. And then we have a lot of different types of community teams that launch out from this facility on a day-to-day basis. We do large-scale outreaches that provide over 40 medical services, including PrEP. And then we also have a number of different smaller types of community outreaches as well, whether that's home visits or mobile clinics in rural or urban areas. In October, we'll be starting Dreams on Wheels clinical services in the communities all around the country. So these are just some examples of the different, you can see that all but one of them provide PrEP as one of the services that are offered. Next slide, please. So our strategy with PrEP has been to integrate it into comprehensive care platform. And we do that with all of the priority services. We feel that if the clients have a broad range of reasons to visit the facility or outreaches, that we can use those different services to draw them in. And then while they're there, we can talk to them about PrEP and other priority services that they can access at the same time. And then I think we probably all know that linking PrEP to HIV testing and counseling is key, and being able to present that immediately to clients, even the same day that they do the testing, they can just initiate on PrEP right there, whether it's in the community or the facility. And then we also spent significant time doing a lot of training and staff buy-in for PrEP, especially last year when it was rolled out as a new initiative. Just to make sure that people were sensitized to this option and really aware of the benefits, and that we're able to communicate that to the clients they were seeing. Next slide, please. So we've always done PrEP initiation since we rolled out PrEP last year, but we then did refills at our facility because we did those outreach initiations all over the country, and we also did have a transport sponsorship program. That meant we had clients on PrEP and ART even from all over the country. But as of April 2019, and partly in response to the COVID pandemic, we were able to launch both community ART and PrEP refills as part of the community drug delivery model. So we have over 60 sites around the country that we go to on a rotation, a 3-month rotation. And then we still offer facility refills as an option for both ART and PrEP and other clients as well. And we do this through what we call our IF2C model, which is intensified facility to community, just meaning that we're taking the facility services out into the community. And we also do PrEP refills at our urban mobile clinic, which has early and late hours to cater for people who are working. Next slide, please. So at all of these outreach modalities, we make sure that we have a nurse and we have counselors so that we can link clients to PrEP immediately when they test negative, if they're interested in that, so that we're not losing people between testing and initiation of those services. And then we also have community cadre who are delivering HIV self-test kits, and then they, of course, refer clients to us for PrEP initiation if they're testing negative. And then we're able to, if there's a group of them, we can send a team actually to their church to do initiations, or we can connect them with one of those 60 sites that we're going to on a rotational basis to do the initiation, whatever is kind of most convenient for them. And we try to maximize efficiencies with teams we already have nearby. The urban mobile clinic, as I mentioned, sees many young women and men in the priority age groups, and it provides these services near factories where they're working. So having early and late hours at that clinic allows people to come before or after work, or even on lunch break. At that clinic, we see an average of 200 clients per day. Nearly 40 of those are already HIV positive. And of the ones that are negative, we initiate an average of 12 clients per day on PrEP, which is about 15% of those that test that day. And then the Dreams on Wheels units, of course, are focusing on adolescent girls and young women, which is another priority population for PrEP, and those will be services in the community level as well, with late and weekend hours. Next slide, please. Sorry, I got a little bit ahead of myself on that one. You can go to the next slide. So while we're in the communities, of course, we have a need at times to take lab samples. So we make sure that we're able to do that, that we have staff that are trained in phlebotomy, and that we have transport capabilities for transporting the specimens safely back to the facility for processing. And then we also utilize the Slack platform as a communication app. And this is really helpful for our teams in the community to be able to keep in contact with the facility and the resources there, whether it's a senior medical team or logistical support or coordination needs. They're able to communicate with one another to help maximize efficiencies and logistics. Next slide, please. So we receive our PrEP medications through central medical stores in the country, and we store them all at the pharmacy at our facility and manage them with an electronic inventory system. This is a screenshot example of our inventory system that helps us to make sure that we're always having enough drugs on hand to carry out the services. Next slide, please. And we also utilize our inventory system to help us create stock lists so that we know what medications. The logistical team follows these stock lists so that they know what medications to pack each day, and they prepare them ahead of time so that nothing is forgotten, and we can depart early in the mornings without delay, and making sure that we're never leaving critical supplies, since we're going out 1 to 2 hours sometimes away from the facility. Next slide, please. We also have a coordination team and a coordinator who works daily at our hub to plan the sites for the upcoming week. The sites for the upcoming 6 months are already scheduled on the calendar, actually, but the coordinator does phone calling and confirmation with community leaders to make sure that everything's a go for the next week's site, and also calling reminders to clients who are scheduled there to make sure that they're still planning to come. This is a screenshot of our electronic medical record where we store, this is an example of some of the upcoming sites that we have. Next slide, please. So when our team is in the field, we always make sure that there's at least one manager who's kind of taking the lead in logistics throughout the day, and he's communicating also with the team back at the facility to raise any questions or just anything that might need to be communicated throughout the day. This screenshot here on the right is another example of our team utilizing the Slack platform. For example, somebody has called the hotline saying that they're having trouble getting to their facility or to our facility for refills during the lockdown. And we were able to respond that we had a team near her area actually that day so that they could attend her as a home visit after they were done. So those are the kind of efficiencies we can use with having a lot of different community teams and having good communication through the Slack platform. Next slide, please. Okay, so this is just an example of our calendar that shows over 60 locations around the country that clients can come to. They can choose their nearest location. We specify dates in advance and then they can choose where they want to come for their next appointment. And they can change that at any time if their location changes between now and their next appointment. Next slide, please. This is an example in our EMR of, on the right, you can see that there's several locations, and then when you click on the location, it shows the upcoming appointment dates for each one. So the people who are doing refills, they are able to select the location that the client desires for their next appointment, and then see the dates will be there, and then align their medications to take them to that date. Next slide, please. So our coordinators call 1 week in advance to confirm the date and location, and we also utilize SMS messages sent from the EMR automatically that remind clients of their visit and prompt them if they missed a visit. The messages are generic so that they maintain confidentiality in case the messages are seen by someone other than the client. And they're also, the client's able to choose their language preference, whether that's in English or Siswati. Next slide, please. We also have a patient communication hotline that's available 24/7. So anyone can call if they have questions, if maybe they have side effects that come up, or they're unable to come to their visit and they need to rebook, or if they need to give us any kind of feedback, maybe on how their visit went, then we encourage them to call and report and give us that feedback on the hotline. We also give IEC materials every time we initiate prep to the clients. Next slide, please. So these are just some of the statistics. We began prep in FY19 Q2. You can see the numbers here, but then you can see in Q3 this year, we did take a hard hit just due to the COVID pandemic and not having nearly as many outreaches where we were coming in contact with clients so that we could initiate them on prep. But in Q4, starting to rebound on that, definitely. Next slide, please. So this just shows some of the statistics at the refills that we've been doing since May of this year. So we've basically done one round, if you will, of refills where we've gone to each of the 60 sites, and now we're in our second round of visiting. So this was the first time people could refill in the community. We did 222, the orange is the prep. So we did 222 prep refills in the last couple of months. And we expect that that will continue to rise as people realize that this is an option. And we also expect that, retention on prep is historically kind of a challenging thing just by nature of what it is. So we do expect though that having and offering refills in the community will help with retention, because as we know, prep really needs to be convenient in order for people to uptake. So we think this will definitely help with the convenience factor. And next slide, please. So lastly, some of the things that have been successful for us in prep, our prep rollout has been taking that client-centered approach and going where the client is, again, making the service as convenient as possible, as well as the comprehensive package and utilizing other services to draw in the clients and then educate them about prep while they're there. Also marrying prep initiation with HTS so that there's no delay between testing and prep initiation really has been key. And then strong logistical support and team communication is definitely needed to ensure the success of community endeavors. And thank you.
That was terrific. It's just an amazing program, Tiffany. We have a number of questions that have come up in the chat, so I'm going to just start from the beginning if I can find here. So one of our first questions was if you could please elaborate on how the HIV self-testing is distributed in community and how these patients are linked with the facility for PrEP initiation.
Oh, okay. Hi, everyone. Oh, normally we have a team of 4 that are leaders here at TLC, who usually working with the community carers that are working outside the community, which then we distributed the self-test kit to them, and they usually give the people out there to the community. Also on our station, as Tiffany have said, to the facilities that we have around the country, we usually have our team who distribute the self-test kits to the patients that normally need them for testing.
And I think I can just add on that. We work actually with the community carers that we work with are churches through the PEPFAR Faith and Community Initiative. So we work with a number of community carers who give those self-test kits out, and then they've been educated on PrEP, and in turn they educate the people that they're giving the kits to. And then if they have people, they follow up with the people they've given the self-test kits to, and then they contact their mentor that is stationed at the TLC facility, as Gugu was saying, and they let us know that they have maybe 5 clients initiated or interested in PrEP initiation, or 10 clients interested in PrEP. And then we work to schedule a time for them to either come to the facility for initiation, or we will send a team out there, or we'll link them up with the closest location where they can get initiated quickly.
Thank you. Somewhat related to that, this is not one of the questions, but a question that triggers in my mind is how often do you do refresher training on the HIV self-testing and PrEP for your team in the field in order to have it run smoothly as you just described?
Yeah, the self-testing, this is a relatively new strategy. It started just in June of this year. We were working with these carers to deliver or distribute the self-test kits. So we did a big training with all of them. We did a big training actually with them in March, and then the rollout was delayed due to COVID. So in June they started distributing, and we've done a couple of follow-up trainings with them. I mean, the actual using of the self-test kits, I think they got that in the first training, and then we've just done some follow-up training, and we also mentor them through WhatsApp groups, and our mentors visit them and call them on at least weekly, just to touch base and to encourage them to be kind of recruiting, if you will, for PrEP, and our staff here that are doing PrEP, I mean, they're initiating PrEP on a daily basis. So we do training for them when they first come on board, and then we do quality assurance checks just to make sure that things are not getting missed when it comes to following the protocols and things for initiation.
Great, thank you. Another question is, do you see any resistance to getting PrEP refills alongside ART? And the reflection along with that is that we hear that one of the reasons young women do not want to go on PrEP is that they don't want to be perceived as taking ARTs. So to what extent is there any stigma associated with the PrEP refills alongside ART? And they're also asking whether whether you provide contraceptive refills as one of the services.
Yeah, no, that's a good question, and it's definitely something that I've heard people raise, but I honestly have not heard, and I'm asking Gugu if she has as well, but I've not heard a single complaint from our PrEP clients that, because the way that we do everything is that we try to make everything is non-labeled. Actually, I don't think that when they come, I don't think they know what their neighbor is here for, or they know what the person sitting next to them is there for. They don't know if they're there for art. They don't know if they're there for PrEP. They don't know if they're there for, SRH, or they don't really know. And when we're going to the community, we don't necessarily advertise, come here for your PrEP refill. We just call our clients that are already with us, and then we tell them we're going to be out there. But even the community leaders that we coordinate with, we just tell them we're going to be following up with our clients. We don't tell them specifically what services we're providing there, just to try to maintain the confidentiality. And I think that approach has worked really well, because we've never had one complaint about merging those two refills together.
Yeah, and to add on that is what is important is just to tell them everything from the start, so they know the difference between art and PrEP, because they usually have the question to say, am I going to take PrEP for the rest of my life? So it's good that they can get the information, the truth from the start before initiation.
Yeah, and maybe Aubrey, you could go back to that slide that shows all the services that are delivered. And what I saw is that it looked like it wasn't just PrEP and ART, but it was many different services.
Yeah, that would be the first slide, I think, or the second slide.
And is family planning part of that?
Yes, we do offer family planning as well. That's offered at almost all of the same entry points, as well as NCD, non-communicable disease, refills, yeah, SRH, condom distribution, and then also like medical consultation. So we just allow anybody, if they, you know, as part of their, we don't invite like maybe the general public to some of these community refill sites, although we do invite them to our outreaches, our larger outreaches, but we allow anybody who's coming, you know, we always take other medications as well so that we can treat any other illness or complaints that they have at the same time.
That's helpful, thank you. Here's a question from Lesotho. From a facility perspective in Lesotho, we have challenges initiating adolescents and young people on PrEP. Our community PrEP partner has more success in this regard. One issue that has come up is parental resistance. Do you have any experience with this, and what are the other challenges you are facing with the same population group, and how have you addressed these challenges?
Yeah, it's a good question. Let's just, I don't think I put the breakdown of our age group. I will say that the majority of our PrEP initiations are probably women in their 20s or men in their 20s to 40s. So I don't know that we've had huge numbers in the adolescent teenage age group. Although we will be doing a lot more emphasis on that in October when we start the Dreams on Wheels support for clinical services. But I mean, we do have a few. I don't know if I am probably not the best. Sorry, that's probably not a great answer.
No, but I think it's you know, you're doing so many things so well. I think the challenge is now for you to go out and get those adolescent girls and young men on PrEP, and then tell us how to do it. No, we all need to learn from each other. So how about this question? What data management platform are you using to link all these visits for a particular client? And for how long do you retain them on PrEP and follow-up?
So we use actually a custom built system it's actually, we made it on the FileMaker platform, and which is just, you can make custom solutions through that platform. And so we have both our inventory system is in one database, and it's more than just an inventory. It has a lot of other organizational functions in it as well. And then we have our electronic medical record in another database. So we've kind of been able, you know, really blessed to be able to have that kind of custom system where we can make changes and additions however we want. And whenever we roll out a new program, we can just add that to the EMR. And yeah, that's been really helpful. And then I think the second part of that question was, can you remind me?
Yes, it's how long do you retain clients on PrEP and follow-up?
Yeah, I mean, it definitely varies. Some people initiate and never returned, certainly. Some people have been on PrEP since the beginning when we started it last year. I would say that most people are not on it that as long, you know, over a year, but I think it also depends on their reason for initiating, whether or not they're maybe in a long-term type of risk situation, or if it's more of a temporary risk situation.
And then this is my question added to that is then, are you able to track cycling of PrEP? Are you able to track these clients who might cycle on and off PrEP?
We can, yeah, we can track that they started this day, ended this day, and then when did they restart. I don't have any data on that. That's a good question. We do some, I guess we're not supposed to call them reinitiations when it comes to PrEP, or we're not supposed to say that they were lost to follow-up, but we do have people stop and start, yeah, and sometimes they stop and start because of risk, and sometimes they stopped because of convenience. So, you know, especially during the lockdown with COVID. I mean, I think there was a lot of people that stopped because of travel restrictions, and you know, with it being really an optional kind of voluntary thing. I think people aren't quite as motivated as they are maybe on art to stay on it when things get tough, like and inconvenient.
Sure, but I just would also encourage you, if you have that, if you're able to look at that data, I think the more we can learn about the normal patterns of cycling on and off PrEP, the more it will help normalize those patterns in the community and reassure us that, you know, as we see people drop off but then come back on as they're, you know, assessing the appropriate risk in their life and when they need PrEP, that would be very useful data for the field.
Yeah, yeah, it's true.
Another question are, what changes or service delivery mitigation efforts have you made during the COVID-19 pandemic?
Yeah, I think the main one was really getting out into the communities and for refills. And I think that's something that we had been wanting to do anyway, because it's a lot more efficient for us to send a small team to a community once every 3 months than it is to have people all over the country, you know, taking public transport to our facility. So, but I think COVID pushed us into action on that, rather than it got it off the back burner, if you will. I think that's really the main change that we made.
There's a question here about, is PrEP for everyone in Eswatini, or do you have a target population, and what are the demand creation strategies you are using there?
Yeah, so I mean, I think PrEP is for anyone who wants it. That's above, I think, you have to be above 16, but then if you know, but if you're below, those that are below 16 that are like girls that are pregnant or have an STI or things like that are also eligible. But otherwise, there is certainly priority populations, which is adolescent girls and young women, and as well as, of course, female sex workers, men who have sex with men, and those populations. But it is available for anyone who perceives themselves to be at risk. And so we do try to give, we actually see a lot of people initiating on PrEP for the reason that they give is because they suspect that their partner might have multiple sexual partners. And that's actually the most common reason, when we look at the data, that people are initiating on PrEP is because they suspect that their partners are not faithful to them, as well as the second most common thing we see is that they themselves have multiple partners, or that they're in a serodiscordant relationship. So those are the three most common reasons we see PrEP initiation.
So now I have a question from me that's somewhat related to that, which is, you know, we just saw in the news that Eswatini achieved 95 for knowing HIV status, on treatment, and virally suppressed. So that's incredible. But I'm interested to hear your thoughts about how does prevention and prevention efforts in PrEP fit in that context?
Yeah, that's a good question, and definitely, you know, the landscape continues to evolve and change as we reach that epidemic control. I think the biggest way that prevention comes into it is now we have to try to maintain that epidemic control, that 95, because if there's people that are coming out of care who are on ART, then obviously those are people who then can contribute, I guess, to new infections if they've defaulted their treatment or if they're not virally suppressed. So I think that there will, because of the nature of ART being a lifelong and medication and adherence being so critical to that, I think that there will always be a place for prevention services.
I agree. Is there anyone else on the panel who wants to reflect on that question? No, that's all right. I didn't mean to. Oh, go ahead.
I was going to say just that I would agree with all that, and I think that PrEP is also important in a context where people may be delayed in being diagnosed, So even if you're achieving 95, 95, 95, if there are substantial delays between infection and diagnosis, then those are people that are in the community with the risk of transmitting, and it calls it into greater importance primary prevention. So for men, younger people, anybody that has a delay between infection and viral suppression, it just emphasizes the importance of primary prevention among those who they may be in contact with.
Thanks for that, Jason and Tiffany. I think that is just an important message. As we celebrate the 95-95, we still need to keep full speed ahead on our prevention efforts.
Can I also add something?
Sure.
Yeah, so the 95, 95, 95, I think probably if you look at the data generally, but we still have pockets of populations that have not reached, that landmark, like the key population. So I think it's still be very important and very relevant for such populations. Prevention remains a key, to helping the population, not just in terms of preventing further transmission, but also being able to help identify those who have not been identified yet as positive and ensure that they're in treatment. The other thing is that we also have, particularly among adolescents and young girls, even young men who are beginning to go into sex or practicing sexual. Becoming actively involved in sex, if we don't have preventive measures in place, there's a possibility that transmission could also be occurring in this kind of population. So I just wanted to chip in those 2 points.
Excellent. Thank you so much, Chris and Jason. Just to continue on these questions, we still have a few more minutes for discussion. Here's a question: how long or how many months maximum are your PrEP refills? So what do you do multi-month dispensing for PrEP, basically?
Yeah, so the maximum length that we can do here is 3 months. After initiation, it's a 1 month and then retest, and then 2 months and then retest, and then 3 months from there. Okay.
Here's a question. You said you often initiate 12 new PrEP acceptors per day, and this is about 15% of HIV negative persons seen per day. Do you have substantial risk assessment checklists and PrEP eligibility assessment forms that help you trim down the number of HIV negative individuals seen?
Yeah, so those numbers were just from our urban mobile clinic. And we do have, risk assessment forms, and that help guide us as far as testing in general. And then, but the counselors do also, as they're doing the HTS process, then walking the client through that counseling portion, then they are assessing their risk factors at the same time to find out what they are, and then talk to the client about what types of prevention opportunities or options they're engaging in, and then making sure that they're aware of PrEP as an option.
So related to that, again, I keep going off topic and on my own questions, but so the WHO has recently sent out a survey, some of you may have received it, that is trying to collect data on what types of risk assessment tools people are using in the field, and figure out how to consolidate and share that information. And I think there are also, I know there are efforts underway in the EPIC team that I work with to look at how do you combine HIV screening risk assessment with, at the same time, PrEP eligibility, meaning can you do one assessment that does the screening for HIV testing, but also then has kind of a decision tree or triage that also identifies then those who should be PrEP eligible. I'm wondering if those are combined, or if they have to go through 2 risk assessments.
Yeah, we actually do have a combined tool, because we figure if they're at risk, I mean, in most cases, like if they're at risk enough to be tested, then they're often at risk enough to be eligible for PrEP. So
Exactly.
we do use a combined tool. We're in the process also of reviewing the tool, because I think, as we all know, some of the challenges with the tool are just getting, I think, honest answers, especially looking at what who, you know, who is asking those questions and in what kind of context, and how well those people are trained. And yeah, so I think it's even for us still, it's a work in progress, just to say what kind of questions are people responding to? Can we ask these questions in a different way? Or yeah.
I'm just looking here to see if, since we're a little bit at time for our discussion, I guess I have been too slow. Let me see. I'll just ask one more question, and then some of the others maybe we can respond in the chat. Do you wait for lab results before giving out PrEP? For how long are PrEP? Oh, we already asked about the multi-month dispensing, but do you wait for lab results before giving out PrEP?
We do not wait. We just do the creatinine test, and we do not wait unless the client is over 50 years old or has significant, has risk factors for kidney disease. Otherwise, we initiate, and then we just monitor results from the lab to make sure that nothing was out of normal.
Okay, and I'm actually just going to ask this one more because it is important. How are you seeing GBV gender-based violence related challenges, and how are you handling that in your program?
We have not had a lot of reports of gender-based violence as a result of PrEP. One thing that's been interesting is that we've found that sometimes it facilitates disclosure amongst partners who didn't know their partner status before. So a person might choose to take PrEP because they're not sure of their partner's status, and then they tell us the next month that, oh, when I started taking this, we talked and he's negative or she's negative, and so I don't need this anymore. So that has been interesting.
Thanks. This was a great discussion and a great presentation. Thank you so much, Tiffany and the Luke Commission team. We're going to move on to our next presenter. I do want to also thank all our participants. We have over 190 participants, and the chat has been great with some really rich questions. For those that we don't get to live, we will try to answer in the chat or with our resource sheet after the presentation. But now let's move on and hear about the Right ePharmacy last mile dispensing and distribution solutions. I'm going to turn it over to Fani to walk us through this.
Thank you, Christine, and good morning, good afternoon, and good evening, I suppose, to everybody around the world. So just a bit about Reef Right ePharmacy. We're a company based in South Africa, and our core focus is last mile dispensing and distribution solutions. That includes innovations, customization, and systemization of medicine or commodity dispensing and tracking. We can move to the next slide. I think it's important that I say that, you know, initially all our programs and innovations was aimed at addressing all the listed public sector challenges. I think if you look at the high demand, and this specifically to South Africa, but I do know that it doesn't change a lot. Maybe one or two things are not similar or familiar with other countries. But obviously the high demand and pressure on our healthcare system. And then, you know, last mile for us is actually where medicine is I would say, delivered into bulk. And we would like to say that we specialize in taking that bulk and doing it in a name-specific patient pack to manage and monitor adherence. But the second thing in South Africa is obviously the shortage of pharmaceutical services, where a lot of the medication are actually given out by nurses, etc., just because of the shortage of staff, and then limited infrastructure, medicine availability, and then a very important thing is manual patient information records and also dispensing records, which is paper-based, and all our programs are aimed at addressing that as well. Then our overburdened facilities, you know, for patients to wait 4 to 6 hours for collection of medication, and then obviously the overall patient experience while queuing. And then the negative economic impact that is not limited to only the country, where people need to take days of work to collect medicine, but also to you know, for the patient to travel long distances and wait a long time and not getting an income while collecting. And then obviously I would say to summarize, obviously the negative impact on adherence, and then ultimately the poor healthcare outcomes. I think that's the setting which got us as a company going, and we've got a few. We're going to show you a few of our programs where we started. The first one is actually in pharmacy automation. In pharmacy automation is where we've taken I would say well-known technology in Europe and America, and we actually pioneered and customized that technology for overburdened facilities within South Africa. I think before we go to the video, I would like to say that we are not PrEP experts. We are experts in the delivering and dispensing of medicine. So I think our slideshow has got a couple of videos in it, and it's just to actually show you what can be done and apply to disease-specific programs like PrEP, etc. We can now show the video on in-pharmacy automation. Maybe just on that, we've currently got 3 robots, and this is the Steve Biko Academic Hospital automation project. You can play.
The Department of Health is one of the Hiv Pharmacy partners in this initiative to streamline patient services at dispensing pharmacies in public hospitals. An example is Steve Biko Academic Hospital, which now has one of the most advanced robotic and pharmacy software installations in Africa. Custom built and adapted for local requirements, the dispensing system improves efficiencies and drastically reduces waiting times for patients on acute and chronic medication. The dispensing software enables pharmacy staff to capture prescriptions and maintain dispensing records electronically. The software triggers custom-built, automated medicine dispensing units to accurately select and dispense up to 3,900 items per hour. This innovative compact robotic storage system requires minimal floor space and can hold up to 28,000 items at a time. The refill system is fully automatic and can be activated to replenish stock after hours. Medication is robotically sorted, scanned and packed in predetermined locations. The system enables accurate stock control and forecasting so that stockouts and the risk of expired stock are minimized. In light of the current shortages of pharmacy professionals in South Africa, in-pharmacy automation aims to scale up service delivery by maximizing on the competencies of pharmacy staff and existing infrastructure at facilities. At the outpatient pharmacy at Steve Biko Academic Hospital, pharmacists can dispense to up to 800 patients a day. The pharmacy has 7 dispensing windows manned by qualified pharmacists who capture scripts on the integrated dispensing system. This activates the robotic dispensing unit to automatically pick and convey the requested medicine to the pharmacists, to label and to provide the required counseling to patients. This dispensing solution reduces dispensing errors and reduces waiting times for medicine collection. This in turn results in improved patient satisfaction and leads to downstream economic benefits of health improvement and productivity. Hiv Pharmacy is committed to finding innovative ways to improve healthcare outcomes locally and globally. We believe that in the near future, patients using public hospitals throughout South Africa will benefit from this pioneering innovative pharmacy automation project. Hiv Pharmacy, the pharmacy of the future.
Yeah, I think to put in context, when we arrived at the 3 facilities that's now fully automated, waiting times were anything from 4 to 6 hours. All the dispensing systems were paper-based. And I think the nice thing about it is if we look back, one of the successes that we've seen is obviously the data that we're working with. You can obviously see we've got the demographics, we've got the age bands. You can go to the next slide. I'm just going to highlight some of the stuff. Then to give you an idea, we've got the Thembaletu HIV clinic, we've got the Steve Biko Academic Hospital and Helen Joseph Hospital, all automated, and up to date we've done just over 2 million prescriptions. Next slide. What we've also done is we've working out a spread for the referral clinics to make sure that we get the dispensing trends per day of the week almost aligned, to ensure that obviously the staff planning, etc., can be done accordingly, and also to avoid overtime and long waiting times. Next slide. It obviously shows us which category medicine we can use, and it shows us the ATC classes, and we also do costing. But it shows you the level of obviously dispensing quality that we get from the systems that we implement. Next slide. I think if you look to the right, obviously there's a lot of benefits, but I think it's very important to highlight the following. What we've seen, this slide is actually old, but what we've seen is the output capacity on all these facilities have increased to over 60%. Same amount of staff, same pharmacy space, and with the efficiency of the automation, we've seen improved output capacity of over 60%. I think the other thing that we need to say is obviously the planning that can be done accordingly is important. Next slide. So this then brings us to, I would say, our flagship product, which is our ATM Pharmacy, or the PDU Pharmacy Dispensing Units, as we know them in South Africa. Actually, South Africa, or Africa, is leading with the installation of these ATM pharmacies, and currently we've got 18 operational. We've just seen since the beginning of the year that some states in the US have passed law to pilot these, and so for us, we've started this journey in 2016 with the first installation, and all of our installations went live end of 2018. I want to say this as well, that some of our solutions obviously is suitable for urban, peri-urban, and rural areas. And what we've seen with the in-pharmacy automation, it can be actually put in a peri-urban and urban area. The ATMs obviously the same, urban and peri-urban. And as we go on to the slide back, we'll show you what we've got for the urban areas. I'm going to show you a quick video to explain to you how the ATM pharmacies work. And I think it's important to note that being on a prep call, prep platform, it's important to note that for now, this is aimed at decanting stable patients out of facilities. We are currently not doing in South Africa disease-specific programs like PrEP on this, but we are in engagement for this to follow. You can go to the video, which will show how the technology works.
Right ePharmacy, together with their donors and partners, are now using electronic and robotic technology to provide an innovative solution for last-mile dispensing and collection of medicine. This service is in support of the South African Health Department's program for the decanting of stable chronic patients from hospitals and clinics to alternative facilities for the collection of their chronic medicine. This initiative enhances patient convenience, improves access to medication, and eases overcrowding at healthcare facilities with high patient volumes. A PDU, or Pharmacy Dispensing Unit, is an ATM-like machine currently being used for quick and easy dispensing and collection of chronic medicines. The PDU sites have been strategically placed at community shopping centers in areas which have high population densities and are close to main transport routes for ease of access and patient convenience. The PDU pharmacy service is free of charge for those chronic patients who have been referred by surrounding government clinics for collection of their medicine from a PDU. PDU pharmacies facilities are open for extended hours and operate on weekends and public holidays. The PDU runs on a cloud-based dispensing software platform which enables remote dispensing, editing and substitution of prescription items, development of an easily retrievable electronic dispensing record, and quick and accurate dispensing of medicine. Delivery of quality pharmaceutical care by telepharmacy interaction with professional pharmacy staff via a live audio-visual link. This proudly South African innovation includes an integrated printer for automated printing and application of patient-specific medicine labels, an automated SMS reminder service to prompt patients when their prescriptions are due for collection or when a new repeat is required. All of this technological infrastructure facilitates direct dispensing efficiency and face-to-face counseling, reducing patient medicine collection frequency and collection time, ultimately improving adherence and making a positive impact on patient healthcare outcomes.
In the past, I had to travel and lose a day of business every month to go collect my medicine at the clinic. But now, hey, the PDU is close by and I can collect 2 months supply of my medicine, which saves me time and it saves me money. I'm a police, quick and easy.
Collecting your medicine has never been this easy. Righty Pharmacy, pharmacy of the future.
Yeah, I think so. Like I said, that's obviously our flagship product, and like we mentioned in the clip as well, South African innovation. And I think you know, you guys being the PrEP experts, I think what you will see is the integration of the telepharmacy towards the robotics is actually ideal for any disease-specific programs. You know, so you know, you can use it in test and start. You can use it in over-the-counter medicine, you can use it in PrEP, you can use it, you know, all, you know, family planning, etc. But for now, maybe just to give you quick highlights of where we are with this program. So we've dispensed 477,000 dispensers, and we've got about 51,000 unique patients. You can obviously see the age bands and the gender distribution on the program. I think it's important that you also look at the stats and the spike that we've seen pre-COVID. You know, one thing about one of the challenges of innovating and customization is obviously, you know, the change management that happens at facilities, but also at the public. And what we've seen is actually that COVID has actually highlighted the importance of innovations, and you'll see in one of our other products as well, we've seen a rapid increase in the uptake. So what we've seen is, you know, we did see a bit of a drop in June, July. But if you take all the typical programs that's aimed at the same, achieving the same in South Africa, we've seen that we've dropped minimal. And I think it's because of the ease of access and obviously the quick collection time. You know, what we've seen is a collection time as you walk into the facilities under 3 minutes, and that includes a consultation with the telepharmacy. Next slide, please. Just more patient demographics. I think it talks to the data quality. What you will see there is, which is important, is you see 69% of our medication is first line ART, 22% is NCDs, and you can see on the right hand corner, in the right corner, you'll see that other conditions are included currently. It's asthma, hypertension, diabetes, lipidemia, epilepsy, gout, and TB. That obviously adds to assisting us not to stigmatize the sites, and obviously when we started this program, you know, we were up about 88% was first line, and you can see that's now dropped to about 69% as we're starting to add comorbidities. Next slide, please. I think it's obviously you look at all the benefits, and like I did mention before, this is aimed at urban and peri-urban areas. You know, it's obviously very convenient for the patients. We put it next to the main transport routes. Obviously, the optimized process efficiency is important. But I also think, you know, one thing that's underestimated is the personalized labeling and the telepharmacy that actually guides the patient to the rational use of medicine. And then obviously, like I mentioned, you know, we currently running at a 92% successful collection rate. And if you manage the patient, you know, outside of the government set rules for accurate collection, we're running at about 98% adherence rate on our patients. Next slide, please. Yeah, I think this is actually one of the more exciting things that we do. We call it collect and go smart lockers. For the listeners in the US and Europe, I think the Amazon lockers or the e-commerce lockers where you get your medication or your parcels that you order online. It's a familiar sight in those countries, but in Africa not. And what we've done is we locally manufactured, I would say, a smart locker for people to actually collect their medication from that has been pre-dispensed. So in essence, where you've got centralized dispensing or mail order pharmacy or multi-month dispensing and distribution to outside of facilities. In South Africa, we've got the CCMDD program, which is called the Centralized Chronic Medicine Dispensing and Distribution Program, or more better known for the DDD models. One of the challenges that we've seen is that the collection points that in the informal settings becomes a problem. Obviously people, it's not convenient. They still need to queue. And then we obviously put our minds to it, and we came up with a customization of a collect and go smart locker. Currently, we've just launched in June, July, 64 locker sites in 3 provinces in South Africa. And just a short clip will show you how the technology works. You can play the video.
Sipho, what are you doing here?
Waiting for medicine, bro.
Why, bro, when you can get your medicine from the collect and go smart locker?
Yeah?
I'm a Pilisi, quick and easy. I only come here for my checkup and prescription.
Oh, how do I do that?
Just ask the nurse about it.
Yeah, it's all good, bro.
Life is for living. Skip the queues. Choose to use Collect and Go smart lockers. Register at your clinic. Receive an SMS with your one-time PIN. Enter the PIN on the Collect and Go touchscreen and collect your medicine. So, Collect and Go, live your life.
Go live your life.
Yeah, so what we've seen, it is the rapid uptake of the collection of medicine at the Collect and Go smart locker sites. You can see there's we're currently standing at 5,000 collections. I think it's important that you realize the fact that this was launched in COVID. So, at facility recruitment was a challenge. So we are actually very excited about the scale of this program. So currently we're in 3 provinces, 63 sites, and also the units are temperature controlled to manage, obviously, and remotely managed. So it's really a low-cost, scalable product, and I think what I would like to add here for the PrEP community is we are currently working on cell phone technology where you can actually preload the lockers, so almost like a reverse logistics capability where the healthcare worker can counsel via his telephone and then obviously select what the patient needs to get and then provide the patient with a unique PIN for collection. So we're basically currently doing the developing for that, and that will probably be in the next quarter, it will be ready. But like I said, this is obviously an extension of centralized dispensing programs or DDD models as we all know them. But very, very ideal for disease-specific programs. Next slide, please. I think this is our last video that I would like to show you. This is in the Free State province in the Mangaung district of Free State, where we were actually asked to put in a 3-in-1 solution, where that includes obviously the ATMs, it includes the smart lockers, but also CDU. That's what we call it, Central Dispenser Unit or DDD, where we actually centralize dispensing in assisting to decant patients out of facilities. This program is quite unique because it's got all 3 of these solutions included in the program and the province. You can play.
patients spend many hours extra taxi fare and take unpaid leave to stand in long queues to collect their medicine at local clinics. Building on their successful track record of pioneering pharmacy innovation and practical supply chain solutions, Right ePharmacy is improving access and availability to pharmaceutical care, ultimately improving adherence, retention in care, and overall healthcare outcomes. Optimized and centralized prescription processing, or CDU technology, enables automated prescription dispensing scheduling that results in effective and accurate high-volume dispensing and distribution of medicine to patients. Custom-designed cloud-based technology supports the CDU to facilitate patient profile creation, prescription capturing and validation, as well as personalized medicine parcel packing and labeling, while also updating the dispensing records of patients during the dispensing process. Medicine is pre-dispensed, packed, patient-specific labeled, boxed and securely transported to temperature-controlled collect-and-go smart lockers, ready for patient collection. Mobile technology is used to keep track of parcels in transit from dispatch to point of collection. Patients have the freedom to choose from which collect-and-go smart lockers to collect their medicine. The collect-and-go patient receives an SMS with an automatically generated one-time PIN notification when their prescription is ready for collection. The patient enters the one-time PIN onto the collect-and-go touchscreen. The locker number appears on the touchscreen, and the specific locker containing the patient's pre-dispensed medicine automatically opens. The patient removes the medicine and closes the locker door. The cloud-based logistics system is automatically informed that this space is now available for the next patient's medicine parcel to be loaded. This easy-to-use collect-and-go option is supported by a telepharmacy call center. This collection capability promotes patient retention, assists in early intervention, and general patient adherence management. This low-cost, scalable technology option facilitates the accurate dispensing, distribution, and collection of medicine. Collecting your medicine has never been this easy. Right ePharmacy, innovative and practical solutions in last-mile dispensing, distribution, and collection of medicine.
Yeah, so that sums it up. I think I hope that we surely stimulated your thinking process in the delivery and the distribution and management of PrEP. I want to thank FHI for the opportunity, and let us know if you've got any inquiries or questions. And thanks again for the opportunity.
Thanks so much, Fani. It's really fascinating and exciting to think of the possibilities. I honestly, my mind is a little boggled at how this all works. That was very helpful to see that last video where you could actually see how the drugs got into the collection box. For the ATM dispenser, how exactly does that work? Like the patient is seen at the facility, the prescription is sent to an ATM, they have to know which ATM to go to, and then how do the drugs go to the ATM? Is it the same as the collection box?
So maybe let me just quickly take you through the patient journey.
Thank you.
Yeah, I think
I'm a little lost.
So how it works. So the patient, obviously, in South Africa, we've got a DDD program within the ministry. So what happens is, if a patient is stable or by the healthcare professional, identifies as a stable chronic patient, he can obviously select where he wants to, collect his repeats going forward, and obviously out of facility, which the PDU sites are some of the options. So what happens then is, as soon as he chooses, let's say, for instance, Alexandra Township or Soweto as his collection point, and the ATM site for the collection point, that prescription gets sent to our staff, where we actually build it into a cloud-based electronic dispensing record. And that obviously, the system includes an automated scheduler. So we know when the patient is expected to come. And we actually ensure that, as we capture the prescription and the dispensing record, the patient's details, including his cell phone, is captured. And he will then be reminded when it's time for the next collection. When he arrives now at the ATM or the collection site, or that he selected, there is staff at site, so currently we are helping the South African Pharmacy Council to build a set of rules to make sure that this innovation can go to scale. And then when he arrives there, he obviously gets issued with a card, as you've seen there. He can also identify himself. He selects his unique PIN. And basically what we then do is we'll talk him and walk him through the process for the first repeat. So then what happens is as he identifies himself at the site, his prescription becomes visible on the screen, but also on the screen of the telepharmacy pharmacist that sits remotely from there. And then the live counseling begins, so the pharmacist can see the patient and the patient can see the pharmacist, and they start obviously engaging regarding the prescription. What specifically does the patient want? Does he want 1 month supply, 2 month supply? And then obviously the dispensing happens if they agree to that. And then at the back end, the robots get filled by staff, on-site staff. So they get filled, and then obviously, but then it's a fully automated process after that. So remotely, the pharmacist then selects the item, the robot picks the item, it actually labels it with the patient's name, dosage, like you get in a normal, I would say, private pharmacy. And then it obviously dispenses the prescription. Then obviously after 23 days, there's an automated reminder sent to the patient again for collection. And then obviously close it, again. And if he's not collecting, he gets another reminder, and then he obviously gets thrown from the telepharmacy to drive adherence. So that's more or less the decanting cycle. So it's obviously government stock that we're using. So that's how that process works.
So there's no money exchanged.
No money exchanged.
And so what you just go ahead.
It's because it's an ATM teller, it's got that capabilities, but in South Africa currently not used.
And so what you just described at the ATM, it's, if I understood, there is actually a person there.
So at the sites, as we roll out this innovation, there is people at the site. There's an information center at each of our PDU sites for patients, for information, etc., and then obviously for on-demand help. It's interesting. We did on our first site, which is Alex Township, we've done an independent study was done to ask the patients, do they still need help? And 94% of the patients came back. They said, no, they don't want any help anymore at the facility. They're comfortable with the usage of it. And as we mentioned, we've got about 51,000 patients currently using the ATMs. So yeah, at site there is staff. Obviously, the technology can be run independently without staff. But like I said, with an innovation like this, the change management is part of the process, and also the legislation that we're driving with the ministry and South African Pharmacy Council.
Okay, I have more questions too, but I'm going to be, I shouldn't, just because I'm facilitating the call doesn't mean I should get all the questions. So I'm going to ask some of the questions that have come through in the chat. I mean, there was a question around eligibility of using the units, but it was answered in the chat, and I just want to confirm that really this program is for stable patients. Is that correct?
Correct. It's
Okay.
for chronic stable patients, and like we say, we don't select them. The healthcare professional at the facility decant them or select them, and there's a fixed criteria and set of rules within government to deem yourself chronic stable by the healthcare professional.
Okay,
Yeah.
and then go ahead.
Sorry, I was saying those are the standard stability criteria, good attendance, but we do viral load, so viral suppression, no complications, and that's regarded as stable. Then they can go to, any of the models.
So one of the questions here was, how do you manage loss to follow-up clients on PrEP? So that should probably be prefaced by saying, have you delivered PrEP through these systems?
Not yet.
And are there discussions underway to do so?
Yes.
That's great. And I guess what we can learn is how you've handled loss to follow-up with some of the other products. So for example, if somebody doesn't come and pick up their medication, what happens and who is notified?
So how it works is, so when we load the system or the patient onto the system, obviously we know which referral facilities he's been referred to from. And what happens is, let's say for instance, he's past the grace period of, let's say, 8 days. Obviously we also phone him from a telepharmacy point of view. Sometimes, you get a patient that we're actually going back to facility for a different reason, but also got his medicine there, and then we can just manage his profile accordingly. Sometimes you get a patient that moves from the area, and we update the file and we send the information back to the facility to be added to his file. And when a patient just didn't collect or is not, and actually in our view not stable anymore, we obviously refer him back to facility in future, and obviously that gets communicated to the facility and to his paper file at the facility as well.
And how about there are questions about any challenges with drug theft or violence near the ATMs or lockers, any other implementation challenges? What about poor internet connection or power outages?
Yeah, so we were very fortunate and blessed that we don't have any issue at our sites. What we actually seen is it's actually endorsed by the community, and it's actually seen as a critical part of the community. We have no stock losses as well, because obviously it's all managed according to the dispensing and distribution system. Regarding challenges, power is a challenge, but all the sites are generated backup, so that takes care of that. I think one of the biggest challenges would be is stable internet connectivity. That is one of the challenges. But we've got a 3-way failover system on all our sites where we actually can go from fiber to 3G to 4G. So it's really being provisioned for that. But I think stability of internet is one of the biggest challenges.
And so I don't know, in your initial conversations about how this would work for PrEP, if you've discussed that sufficiently to be able to reflect on what you think some of the challenges versus benefits might be.
Like I said, I'm not a PrEP specialist, but I do think, what we are currently busy with is obviously, telepharmacy and e-health is actually one of the most important things currently happening in the healthcare sector. But if you just take the power of a smartphone these days, where a patient can be seen by a healthcare professional, and put all his stuff, all his information, demographics into the cell phone, and he can actually refer him to a PDU site for collection. It's not necessarily that you need a card or anything, you just need a PIN. And obviously then the other thing is you can also do remote counseling and discussions as well for PrEP, and just refer it to one of the solutions that we've shown.
How do you maintain confidentiality with the remote counseling?
So I don't know if you've seen that the ATMs are, it's almost like it's got like a semi-private area, and obviously there is a phone set as well. If you don't want to have the chat, I would say louder, you can just pick up the phone set. Then it's like almost like having a call. So that's in essence how we do it. So the telepharmacy, I think, to give you an idea how far our furthest site for PDUs and telepharmacy are currently 420 kilometers away. So it's actually amazing to think you're doing live dispensing 420 kilometers away. But confidentiality is not a challenge for us.
I also noticed
I think Fanny, maybe to add, again, as Fanny says, very or no experience with PrEP, but thinking of where we place these lockers, right? If they are placed in a supermarket, for example, so the access would be 24 hours. So, PrEP clients who perhaps, would be busy evening, afternoon, so they can access. So accessibility would be great then for anyone, not just a PrEP client. And we do have complete patient records. So the tracking and tracing, I guess, the tracking certainly would be much easier because we'll know within a day or two if collection has happened or not, and then put into place your, your community tracking and tracing, or whichever way you are doing that. Just to add on that.
Yeah, that's very helpful. Thank you, Eula. I noted on the numbers of, when you showed the numbers of the demographics of the people who use this system, that it tended to be more, I want to use the term older, although I'm older than those age groups, but it did not seem to have very many of the young people engaged. So I'm just interested in how this type of system works for younger people and key populations.
I think to give you an idea, what we've started, when we started, the age bands were actually higher. And just remember, like I said, it's a relatively new innovation and program. So what we've seen is the age bands are coming down. I do think it's a lot to do with, obviously, this. We can drill it down even further per township. And it actually varies from township to township as well. But I think it's for us. I think the data is actually showing us where we need to direct all the frontline and ground staff of the local NGOs, etc., and ministries, where the education, etc., needs to happen. But what we've seen is the age does come down, and what we've also seen lately is it's important to know that these ATMs are available 7 days a week, and so that's already about 50 hours more availability than your healthcare facility. And what we've seen is the youngsters are starting to use the technology over weekends, especially Saturdays and Sundays. So I think it's also about, the workforce, maybe in the week they're not there. Over the weekends, we've seen an increase in the younger population. But yeah, there's still a lot of work regarding change management and marketing of the PDUs in the future. So I think it will starting to tell as we go on.
Thank you. I have one more question. How is the feedback from the community?
So it's interesting. It really, we've got amazing feedback regarding the ATMs and the collect and go smart lockers. We've been overwhelmed with radio station interviews, community radio station interviews, TV interviews, etc. As the word's starting to spread.
And the Prep Learning Network.
And the Prep Learning Network. There we go. So yeah, we've been very fortunate in that sense. And like actually this morning we were asked to do a full panel on Alex FM, which is the local radio station and in our first rollout. So yeah, so it's really been seen and received well. And like I said, it's almost now part of the communities. The most interesting thing for us was actually the launch of the Collect and Go Smart Lockers, which was actually only due to happen later this year. We were requested to fast track that, and we went live with the first 1 or 2 lockers in May. The rest of the lockers actually started to roll out in June, July, and I think by the 25th of August, we've already decanted or had 5,000 patients collected. So it just shows you the rapid uptake on the Collect and Go smart lockers regarding pickup points. But I think the ATM has paved the way for that, So what we've done with the Collect and Go smart lockers, that is obviously, like I said, an extension of another program in South Africa to decant patients. But we've went more of a rural area, rural approach. Although it's in peri-urban areas as well, it's more in a rural area. And I think, those figures are quite encouraging if you think it's still, South Africa is in level 2. We've had the longest lockdown of all the countries. And in that time, we managed to bag 5,000 patients that select the Collect and Go for collection.
Yeah, no, it's really terrific and very exciting. And I look forward to hearing how PrEP it can be dispensed in it through these systems in the future. I'd like to move on to some of the closing slides. One more, Aubrey, just so people can see what's coming up. But before we talk about that, I want to pause and give a moment to all of our panelists to see if anyone has any final comments or reflections they'd like to share with the group. No, okay, that's fine. It was a very robust discussion. I really want to thank Tiffany and Fani and your teams for these incredible presentations and sharing your learnings. For those who aren't familiar with the PrEP Learning Network process, what happens after this webinar is that we will post the recording on our website, which you can see a link to right here on this slide. And then we will take all of the questions and answers and put them together in a resource sheet along with links to other materials that may be relevant to this discussion. And we will share that out with the full group probably in about a week. So please keep a lookout for those resource materials. And hopefully I think there has been a question for some additional questions that have come through that haven't been answered, and we'll try to address those in the resource sheet. I do want to highlight that our next learning webinar is on September 24th, a month from now, and we're going to move away from oral PrEP to a vaginal PrEP. The Dipivirine vaginal ring was just recently received a positive scientific opinion from the European Medicines Agency and is undergoing WHO review right now. So we anticipate that this will be a new pre-exposure prophylaxis option for HIV prevention that will enter the marketplace in the coming months. And so we want to talk next month about this. What is the Dipivirine vaginal ring? What are the timelines and steps that need to take place to move it into the marketplace? And what will this look like to have another HIV prevention option in our toolbox? So very exciting times. We hope you will join us. Aubrey will be sending out registration links, etc. for that. Is there another slide, Aubrey? Oh, yes, we have a Twitter account, the PrEP-LN Twitter account. It used to be Options, now it's PrEP-LN for Learning Network. And I mentioned that we would be sharing the webinars and resources. So without further ado, I will just say thank you to everyone who participated. What an incredible group we had in the audience with really great questions and a terrific speaker and panelist list. So thank you all for your time and attention today, and I wish you all a good day and evening.
Thank you, and thanks for the opportunity. Goodbye.
Bye.